So we put the patient in a pressurized conditions, and then we ask the patient to inhale the oxygen. We were looking to explore this possibility for cancer treatment and also to make lives better for our patients. Rate of hearing recovery was much higher when we add HBOT to the standard treatment. The best results of HBOT are found when the HBOT is added within the 14 days of treatment.
So thanks everyone for joining this session. Today we shall be hosting a webinar where we shall be discussing the role of hyperbaric oxygen therapy in treating sensorineural hearing loss. As a quick background, my name is Arpan Talwar, and we are part of an association called HBOT India. We are a digital platform where we propagate the knowledge for the use of hyperbaric medicine in India. Along with that, we also have our own center for hyperbaric medicine based out of Gurgaon in India. Today we have with us Dr. Mandeep Singh Malhotra, who is the chief mentor for at our center, HBOT India. I would hand over the discussion here on to Dr. Mandeep to introduce himself and give us the knowledge on the use of hyperbaric medicine in the cases of sensorineural hearing loss. Welcome, Dr. Mandeep, on this webinar. We would like to hear more from you on this technology and how we can benefit for the patients with sensorineural hearing loss. Thank you so much.
Thank you, Arpan, and my greetings to all my esteemed colleagues, my seniors, my contemporaries, and my friends from the ENT fraternity. So, as my introduction says, that I'm a surgical and a molecular oncologist. Plus, I got my hyperbaric certification last year from South Carolina. So, just a brief background about how we got into hyperbaric. So me and Arpan are the founder members for this HBOT India, and so we are cancer guys, and we were looking at hyperbaric medicine, and specifically it is being used in advanced cancers when the cancers become refractory to systemic medicine, specifically cytotoxic chemotherapy. Because of the increase in hypoxia, the cancer cell doesn't allow chemotherapy to work. So that is where the role of HBOT is in cancer. And we were looking to explore this possibility to for cancer treatment and also to make lives better for our patients. And simultaneously, after my certification for HBOT, the another problem which cancer is still in, I would say, it's in very elementary and initial stages. But the other problem which we actually discovered was sensorineural hearing loss, which has a very, very important role of HBOT. And this webinar, actually, we just wanted so that a proper coordination between the ENT fraternity and the HBOT centers should be there so that the maximum benefit of patients can occur. So, obviously, the ENT fraternity would be knowing much more about sensorineural hearing loss than we would even imagine to understand that. But yes, it's a profound problem. Now, there are millions of people who get and who suffer from this problem. And definition, as you must be knowing much better than me, is that we label it as sudden sensorineural hearing loss when it affects at least 30 decibels across three consecutive frequencies for 3 days. And the important fact is that around 90% to 85% the cause is unknown. And hearing function in the inner ear is basically the problem is that in cochlea, the demand for oxygen is very high. So there is a very high metabolic rate for hearing cells, and direct blood supply to organ of corti is minimal. Oxygen must diffuse through the perilymph and cortilymph. The labyrinthine artery, which is the branch of internal auditory artery, is long, slender, and it is a branch of the anterior inferior cerebral artery. in 85% of the times, and 80% of times it is basilar artery. The issue is that because of its a single end artery, any episode of vascular insufficiency, which might be due to some infection, some inflammation, a microangiopathic issue, can lead to ischemia and toxins which can deprive inner ear cells of oxygen, which leads to damage. And cochlear hypoxia is then associated with progressive ossification, fibrosis, loss of neurons, endolymphatic hydrops, and ultimately. So, the standard treatment for sensorineural hearing loss is, as my ENT fraternity practices, and they are the experts in this, we want to limit ourselves to the exact role of HBOT in this treatment. The standard treatment is corticosteroids, vasodilators, anti-inflammatories. The HBOT, so basically, I would first like to just share a brief note of what exactly HBOT is and how does it actually benefits. So HBOT is we put the patient in a pressurized conditions. It is from 1.5 to 3 atmospheric pressures, and then we ask the patient to inhale the oxygen. So it is according to the Henry's law, that is on which most of our aerated drinks also work, that if you increase the pressure, the dissolvability of a gas in a liquid is increased. So similarly, when we have our patient in a high pressure atmosphere and we ask them to inhale the oxygen, so this oxygen, apart from the hemoglobin saturation, will get dissolved in the blood plasma. That is the liquid part of the blood. It is nothing to do with the hemoglobin part of the blood. That is naturally how you inhale the oxygen. So the plasma oxygen concentration, if I raise my pressure to around 2 to 2.5 atmospheric pressures, the plasma oxygen would increase at least 10 times. So this blood plasma oxygen is the one which goes to the end organs, and it diffuses very swiftly from the blood plasma to the endolymph or cortilymph and reach to the end organs, which are, that is, hearing cells and nerve cells, which actually need oxygen for their repair, regeneration. And that is when we have increased oxygenation, the hair cell function and recovery increases, neovascularization is increased so that new blood vessel formation occurs. The inflammation, the high oxygen, reactive oxygen species is high, so inflammation is reduced. And also those hearing cells or nerve cells which are at the border of ischemic death, so they would the neuroplasticity basically, so those cells then start regenerating and their survival increases, and that is how it contributes in regaining the hearing function. So there was a study of Krachkovika, and in that they looked into the use of HBOT as a supplement to the first line medical treatment. And what they found was that the proportion of patients with hearing gain was 28.6% in those treated with steroids alone. And if that steroids were combined with HBOT, the hearing gain increased to 61.7%. In Chu et al., in their study, they showed that the rate of hearing recovery again was much higher in when we add HBOT to the standard treatment. So it is 60% versus 33%. In Liu et al., it was they divided their group in 60 patients treated only with oral prednisolone and Ginadon, and the other they added HBOT. And what they found was that the complete recovery or improvement was found in 66.7% of the patients with medicine only group. And when the HBOT was added, this recovery increased to 86.7%. So Rietel it is again, they have a very large experience, and they have showed that the effect of HBOT when used as a part of combination is significantly higher. So there is one recent study by Skarazinski et al., which was published in July 2023 in Frontiers of Neurology. There's specific edition of Neurotology, in which when they looked into patients who just received one group which got treated with glucocorticoids and the other was glucocorticoids with HBOT again, and they found that the outcome was similar. But when they analyzed this, they themselves in that paper they had suggested that the treatment delay was very relevant, and patients were reported to their clinic 2 weeks after the onset of sensorineural hearing loss, which again is a very important factor when we are looking into the role of HBOT in sensorineural hearing loss. So this is the Joshua's meta-analysis, which was published in JAMA Otolaryngology, and in this it suggests that the absolute benefit in gaining hearing gain is around 6.3 to 14 decibels. And what they recommend is that the HBOT session should be around 900 to 1200 minutes of 2 ATA. So if we are giving an hyperbaric HBOT of just 1.5 ATA, it will not benefit. The benefit will start occurring if the machine is capable enough to deliver the atmospheric pressure of 2 to 2.5 ATA. So a 2 ATA machine is essential. The HBOT sessions has to be around 900 to 1200 minutes to have a significant impact. Just a 2, 3, 4, 5 sessions will not have that much effect. So it can be either 10 sessions of 90 minutes or 15 to 20 sessions of 60 minutes if we are looking into a smaller sessions. An also important fact is that HBOT should be started within the 7 to 10 days of hearing loss. Therefore, it is safe that when it is applied within that, so the patient is diagnosed with hearing loss, the corticosteroid treatment or the mind ENT fraternity starts their treatment, and simultaneously the HBOT is added to the standard form of treatment. The Heather Murphy et al. Suggests that the best results of HBOT are found when the HBOT is added within the 14 days of treatment. And also, the American Academy of Otolaryngology recommends that adding HBOT after 3 months also is not beneficial. And HBOT as salvage that we treat with corticosteroids and still the recovery is not satisfactory, then we add HBOT, and then also in salvage setting it has limited efficacy. So the important fact is that HBOT should be added along with the standard or conventional treatment. And yes, Murphy suggests that the follow-up audiogram should be first in 10 days and then after 20 treatment, but that we basically would leave it to our ENT fraternity to decide. We won't interfere into that. And there is just important few things about certain adverse effects or contraindications. So mild medullary paratrauma is the most common complication. It is around 13%, but it is vast majority. It resolves by itself. It doesn't have much sequelae. There is just oral decongestants and proper air clearing techniques. So what we in a center practice is that we don't go with for 2 ATA directly. We would start with 1.5 ATA, and within 3 to 4 days we try to reach to 2 ATA. Then gradually by 7th, 8th day we reach around 2.25 ATA. So 2.25 ATA is something which we normally try to practice as a standard for sensorineural hearing loss. But for us to reach to 2.25 ATA, it takes around 4 to 5 days or even sometimes 7 days. Certain patients who obviously are claustrophobic or they have confinement anxiety, they are not a candidate. Patients who are having severe congestive heart failure, any severe reactive airway disease, pneumothorax, or certain medicines which cause pulmonary fibrosis like doxorubicin or bleomycin. So these patients should not be given HBOT. As a prerequisite, in our center, we definitely get the X-ray, physician clearance, and ECG before starting an HBOT for a patient. And ultimately, yes, it has to be the clearance has to be given from your side before we start any HBOT treatment. So, thank you everyone, and we'll be happy to take any questions if you have any.
Thank you, Dr. Mandeep. So we request all our participants, in case if there are any questions, please feel free to share your questions, and we would request Dr. Mandeep to answer those questions. So we have our center in Gurgaon, in Sector 51 in Gurgaon, which is just up behind Artemis Hospital, which is very near to the Artemis Hospital. And we shall definitely try our best to connect with all the doctors who have attended the session to share further details about the center in a day or two. So once again, from our side, from HBOT India, a big thanks to all the doctors, our fraternity who has joined this call. I hope the session was insightful, and we together can lead to better outcomes for the patients. I would also like to thank Dr. Mandeep for taking out time for this particular webinar sessions. And I hope together, all with a combined effort, we shall do good to the society. Thank you very much, and have a great day ahead.